USMLE style question. A 2-year-old girl is brought to the pediatrician due to recurrent nosebleeds and easy bruising. Her parents state that she has had prolonged bleeding after minor cuts and scrapes. There is no family history of hemophilia or von Willebrand disease. Physical examination reveals multiple petechiae and ecchymoses over her arms and legs. Laboratory tests show platelet count 250,000 millimeter, normal, bleeding time, prolonged, prothrombin T, normal, activated partial thromboplastin time, APT, normal. Platelet aggregation studies, absent aggregation in response to ADP, collagen, and epinephrine, normal response to RISTOCETIN. Which of the following is the most likely diagnosis? A. Bernard-Soulier syndrome, B. Glanzmann thrombasthenia, C. Immune thrombocytopenic purpura, ITP, D. Thrombotic thrombocytopenic purpura, TTP, E. Von Willebrand disease. B. Glanzmann thrombasthenia. Explanation. Glanzmann thrombasthenia is an autosomal recessive disorder caused by a deficiency or dysfunction of glycoprotein 2,3a, GpIIb3a, which is essential for platelet aggregation. Since GpIIb3a binds fibrinogen to link platelets together, its absence results in defective platelet-to-platelet aggregation and a prolonged bleeding time. Key features of Glanzmann thrombasthenia. Clinical: mucocutaneous bleeding, epistaxis, menorrhagia, gingival bleeding, petechiae, ecchymoses. Labs: normal platelet count, unlike ITP or TTP. Prolonged bleeding time due to defective aggregation. Normal PT and aPTT, coagulation cascade is intact. Platelet aggregation studies: no aggregation with ADP, collagen, or epinephrine because GpIIb3a is required for aggregation. Normal response to RISTOCETIN. RISTOCETIN tests platelet adhesion via VWF GpIIb, which is intact in Glanzmann. Why the other choices are incorrect? A. Bernard-Soulier syndrome, GpIIb defect, platelet adhesion problem, thrombocytopenia with giant platelets, abnormal RISTOCETIN test. C. Immune thrombocytopenic purpura, ITP, autoimmune platelet destruction, low platelet count, no aggregation defects. D. Thrombotic thrombocytopenic purpura, DAM-TS13 deficiency, microangiopathic hemolysis, fever, renal neurosymptoms. E. Von Willebrand disease, VWF deficiency, increased aPTT in severe cases, abnormal RISTOCETIN test. Key takeaways: defective GpIIb3a impaired platelet aggregation, prolonged bleeding time, normal PT aPTT, no aggregation with ADP, collagen, or epinephrine, normal RISTOCETIN test, unlike Bernard-Soulier or VWD,